was 3 years of tamoxifen, then 5 years of tamoxifen, now 10 years of tamoxifen, and similarly for aromatase inhibitors, it is like 5 years of, then 7-8 years of aromatase inhibitors. Do you see that similar thing happening for CDK4/6 inhibitors, like at present 2 years, maybe in the later?
Of course. I mean, when we're looking at the adjuvant endocrine treatment, I think first it's very important to cover the first few years of recurrence, that we have this high risk of recurrence that's in the first few years covered with an endocrine treatment. And we've learned from patients at a higher increased risk of recurrence that it makes sense to extend that to 7 to 8 years, and in some patients with a higher risk even to 10 years. And the therapy is well tolerable, even if it has its problems, it's quite well tolerable, so we're okay with extending the treatment to even up to 10 years. The CDK4/6 inhibitors, I would like to see a study that might extend it to 5 years, because we know it's also well tolerable from the metastatic setting. But nevertheless, we have more problems than with the endocrine therapy alone. And I'm happy for now with the 5% difference that we see in NATALY and the 6 to 7% difference in the high-risk population of Monarch E. So for now, I'm pretty happy with what's going on. And I don't see a study happening that extends the therapy duration at the moment. Although maybe in the future, when the therapies are more available, some study group might do it.
Thank you. We have seen many of our patients are facing problem of like elevated transaminase level with dual therapy, especially, and some patients going to the extent of doing liver biopsy and all these things, whether to rule out like any occult liver metastasis there. So how often you find that like elevating liver enzymes is a real problem in your scenario?
Liver enzyme elevation with the ribociclib.
Yeah.
So we see a liver enzyme elevation with the ribociclib at a rate that might be clinically relevant in about 9 to 10% of the cases. But most of them are not with a bilirubin increase, so I wouldn't suspect that there is a substantial liver tissue damage. And then, of course, you have to do the respective dose interruptions and or dose reductions and see whether you can come back to the dose that you started with, or you continue the therapy at one dose level down. But most of these cases are very well to be handled with the respective dose interruptions and dose reductions.
Thank you.
Thank you very much.